I'm Gary Skanke. I'm an infectious disease specialist. Been here for 25 years. I haven't been rounding too much at Sunrise Hospital, primarily out at Centennial Hills, but I've been very active in antibiotic stewardship and infection control, and but I'll be speaking primarily about antibiotic stewardship, which has been a topic of primary concern, not only to the hospitals locally, but to hospitals nationwide and to Medicare and CMS, and in fact has become a CMS initiative. I noticed the flyers in the HCA hospitals and the doctors' dining rooms, and noticed that someone had made the title of my talk something about ethics, and I realized that the PowerPoint slides that I had at that point put together had nothing about ethics. So I decided to put together an ethics slide. Okay, here we go. So this is my ethics slide, which makes it an ethics talk, I guess. And I thought, well, okay, well, what's ethics? If you look it up in the dictionary, ethics is a system of moral principles. So I guess the question in trying to relate antibiotic usage with ethics is it moral to give a medication to a patient that he or she does not need? All right, so we're going to be talking about antibiotic misuse and overuse. 30% of antibiotics prescribed in offices and ERs in hospitals, according to the CDC, are unnecessary, according to a May publication in 2016. Most commonly, these are prescribed for viral illnesses. About 56% of all hospitalized patients receive antibiotics, and half of those are inappropriate. 95% of those patients have received the incorrect diagnosis. About 38% go on to receive the correct diagnosis but receive the wrong antibiotics for that diagnosis. Types of antibiotic misuse include antibiotics when there really is no infection, but the physician, being uncertain of the diagnosis, is using the antibiotic in a just in case there is an infection, or cover your arm situation. Use of antibiotics for non-bacterial infections, underdosing antibiotics, and we'll talk about that later, not following clinical guidelines and using wrong diagnoses, and we'll get into that later, unnecessary combinations or polypharmacy, not de-escalating antibiotics, or not discontinuing antibiotics when they're no longer necessary. The impact of antibiotic misuse cannot be understated. It drives multi-drug resistant organisms. It increases the cost of health care. The estimated cost is over $80 million on a daily basis nationwide in hospitalized patients in drug costs only, not to mention other costs such as the impact of multi-drug resistant organisms, increased length of stay, etc. It subjects patients to potential side effects, increases the risks of attendant complications such as line sepsis and increase the risks of development of other problems such as Clostridium difficile infections. As far as multi-drug resistant infections are concerned, length of stay as a result of these kinds of infections is 1.5 to 2 times longer. Increase the cost of stay by 1.57 to 2.9 times more, and increases the mortality of each patient by up to 9 times more. This is a very old slide, but I've just put this in as a demonstration that the amount of drug-resistant organisms are increasing. This just goes up to the year 2000. The graph on the left shows third-generation cephalosporin-resistant Klebsiella, which we nowadays call ESBL-resistant organisms, and that's on the increase. On the right, fluoroquinolone-resistant Pseudomonas. Here we see an increase on the left of MRSA, and on the right an increase in the prevalence of VRE, vancomycin-resistant Enterococcus. All these things are on the increase, and much faster than they would have if we would be controlling the use and appropriate use of antibiotics, but accelerated because of inappropriate use of antibiotics. So the antibiotic stewardship has been created for the purpose of trying to encourage responsible and judicious use of antibiotics and reduce its inappropriate use. It's now a requirement of CMS that every hospital have an antibiotic stewardship program, and in fact it's monitored by a joint commission. A joint commission, when they come by, will be monitoring what steps each hospital is taking to reduce the amount of antibiotic overuse. They'll be monitoring physician education and the different steps that the antibiotic stewardship will be taking. The expected outcomes of antibiotic stewardship include reduction of the cost of health care, reduction in the prevalence of the multi-drug resistant infections, reduction in the number of C. diff infections, reduction in adverse reactions and complications from the antibiotic use, but most importantly, it will hopefully improve quality of care and improve patient outcomes. The interventions of antibiotic stewardship include antibiotic formulary restrictions. Certain antibiotics are going to be restricted only to infectious disease specialists' use. Assessment of appropriate antibiotic on a case-by-case basis. So the pharmacists in the hospitals will be monitoring antibiotic use. The pharmacists will be calling physicians and encouraging de-escalation. In other words, narrowing the spectrum of antibiotics or switching to the oral form or stopping antibiotics if there's no evidence of antibiotics, no evidence of infection. Pre-authorization may be necessary for certain kinds of antibiotics. Antibiotic usage data will be collected and analyzed on a case-by-case basis, not only per patient, but also per doctor's prescribing habits. And from my standpoint, most importantly, we will be having an important thrust in physician education, and this lecture today is part of that, where we will be emphasizing looking at clinical guidelines, acknowledging that they're there, and having the physicians look at clinical guidelines more and referring to those so that they can identify when antibiotics are indicated and when they no longer are. So let's look at the phenomenon of antibiotic misuse and overuse. Why are antibiotics misused? Well, one possible reason is that doctors react to cultures rather than analyzing them, something that I call the knee-jerk reaction. There's a positive culture, and the first thing a doctor does is throws an antibiotic at it, rather than analyzing and determining whether that culture truly represents an infection. Another possible reason would be that there's inadequate knowledge or lack in confidence in himself in how to diagnose an infection. In this case, the antibiotic becomes sort of a security blanket. Okay, well, we've got things covered. He's on an antibiotic. All right, we're covered. We feel better. Another possible reason is that there's a poor understanding of what the treatment recommendations are. Doctors avail themselves infrequently of the medical knowledge that is out there, the medical literature. Back in the old days, 20 years ago, if you wanted to consult the medical literature, you had to leave the hospital and go find a medical library someplace. You had to muddle through Index Medicus, and it took you hours to find an article on what you wanted to do. Now you've got uptodate.com on your handheld, and you can immediately access medical information. So this information is readily available to you right there on the nursing station. So there really isn't an excuse not to consult medical literature. Another reason why antibiotics are used is fear of litigation. And sometimes, especially in the outpatient setting, antibiotics are used unnecessarily because the patient insists, I want an antibiotic. And we'll cover some of these. So let's kind of talk about how antibiotic stewardship applies in the inpatient setting. A lot of doctors look at diagnosis of infection as a great black box. It's a mysterious thing. When is there an infection? Someone comes in the hospital, they're really sick. Is this patient septic? Well, to make a few points, first of all of us that have gone through medical education, medical school, residency, fellowship, whatever, we've really already received the basic understanding on how to diagnose an infection. Now, I'm not talking about things that only an infectious disease specialist should know, but I'm talking about just general concepts that any physician should know. When is there infection and when is there not infection? And some basic points are these. First of all, no diagnosis is made by a single test. And I make an apology here to the radiologists who frequently will call a chest x-ray a pneumonia. Well, you can't quite do that without also seeing the white blood cell count and seeing what the patient's temperature is and listening to his lungs and getting a history. You can say that the patient has a consolidation on the film. but you can't make a diagnosis from a single test. You have to assess multiple data points. You have to look at as much information as you can. Infection is diagnosed clinically and not by cultures. And when I teach my residents and medical students, this is one of the biggest surprises that comes when I tell them that, guess what? We don't diagnose infection by cultures. We diagnose infection clinically and then use the cultures to try to determine what bacteria is causing that infection. Medicine is truly a science of probabilities. The percent of probability of presence of an infection is based on how many positive data points there are that point towards that clinical infection based on clinical findings of history, radiographs, lab studies, all considered together. And the more data points that can be considered, the more accurate the diagnosis is. So just as an example, let's look at a patient who comes into the emergency room, and if they have a fever, leukocytosis, a productive cough, infiltrates on chest x-ray, and for the sake of argument, let's say that when we listen to their lungs, there are no crackles, and the blood gas is normal. Well, we might say there's a 66% probability that that patient has a pneumonia. Well, that's probably enough of a probability that I am willing to treat this patient for pneumonia. If, however, we've got a patient who comes in the emergency room without fever, with no leukocytosis, no cough, but there's an infiltrate on the chest x-ray, no crackles on physical exam, an abnormal, a normal blood gas, I would say probability of pneumonia is 16%. But I can tell you that in a significant number of cases, that patient will be started on an antibiotic. And the probability of that patient being started on an antibiotic increases if the radiologist uses the word pneumonia in his dictation, in his report of the chest x-ray. Just to make another point, let's say a patient comes in the emergency room with dysuria, urinary frequency, and pyuria. But he does not have flank pain, and he does not have fever. Probability of pyelonephritis is 60%. So that's a probably good probability of pyelonephritis. However, usually you won't consider someone to have pyelonephritis unless they have fever and flank pain. So some of these data points are actually weighted. So this probably represents someone with cystitis rather than pyelonephritis. But the more data points you obtain, the more likely it is you're going to make an accurate diagnosis. So getting some more information here, for example, getting a CBC would lean you more in the diagnosis, towards the diagnosis of pyelonephritis, and a high white blood cell count would lean you more towards that diagnosis. So looking at the data points, more data points, will help you determine whether there's infection and whether there's not. And please note that in none of these cases were the diagnosis made with a culture. Okay, many times when you're seeing a patient in the hospital, cultures have already been obtained. Sometimes a patient has been in the hospital for a while and is running fevers, and someone else orders cultures. What we need to do is avoid the temptation to treat the culture results. We have to analyze the culture results. So let's take the example of a positive sputum culture. If a sputum culture comes back growing an organism, we need to ask ourselves, does this represent infection or is it colonization? So some of the things that we look at, some of the questions we need to ask are, was there any new or worsening infiltrates on the chest x-ray? Does the patient have new or persistent fever that's otherwise unexplained? Is the white blood cell count increasing? Does the patient have persistent or worsening hypoxia? Does the patient have purulent respiratory secretions? So this is a sputum gram stain that shows many, many white blood cells and a monomorphic smear. In other words, we see one type of bacteria here, gram-positive cocci in pairs and chains. So this is what you want to see in a gram stain. If you got a sputum culture that had a gram stain that showed many white blood cells and a monomorphic smear, then the sputum culture is probably going to be reliable. If, however, you have a sputum smear that looks like this, with these large squamous epithelial cells and a polymorphic gram stain with gram-positive cocci, gram-positive rods, gram-negative rods, gram-negative cocci, then the sputum culture is much less likely to represent an accurate culture. Some people will get a urine culture on a patient, and so now you need to try to identify whether this urine culture represents a true urinary tract infection or not. So the questions you would ask would be, is there significant pyuria on the urinalysis? Does the patient have a long-term Foley catheter, which may also give you numerous white blood cells or a significant number of white blood cells in the urine without there being an infection? Does the patient have a new or persistent fever? Is there a leukocytosis? Or is there evidence of contamination? One thing that we many times, in fact, almost always overlook on a urinalysis is the epithelial cell count. That's down at the bottom of the urinalysis. If there are many epithelial cells in the urine, then the urine culture that comes from that specimen is likely to be contaminated and may not represent a true urinary tract infection. So this is a smear of a urinalysis, and this is what you want to see. All these round things here are white blood cells. So we want to see lots of white blood cells. What we don't want to see are these large epithelial cells. And when we see epithelial cells in the urinalysis, if a urine culture was obtained at the same time, that urine culture probably represents a contaminant. Therefore, that urine culture would not represent a true urinary tract infection. Here's another type of culture that you need to be able to understand. What if you see a positive wound culture? How do you determine if a positive wound culture represents a real infection? Well, you've got to examine the wound. It is said that the best way to hide something from an internist is to put a dressing over it. Well, you got to take some dressings down and actually look at the wounds. Examine the wound. Is there pus? Is there present? In the vast majority of cases of C. diff, there is leukocytosis. So if a patient has diarrhea but no leukocytosis, C. diff is highly unlikely. Also, interestingly enough, nurses' noses are pretty darn good at diagnosing C. diff. And there was actually a study done that showed that their sensitivity is about 70%. You ask a nurse, and they're 70% of the time they'll be right. I've often asked the nurse, well, if it smells like C. diff, how's it taste? And they usually ask me to taste it. And now, the first toxin assays that came out for C. diff were insensitive. So we had to get 3 stool specimens to be able to increase the sensitivity enough to make the diagnosis of C. diff. But the newer toxin assays and now the PCR are so sensitive that all we need is just 1. So we get 1 stool specimen. So only 1 should be sent. I'm going to spend only a short time on treatment of C. diff. And as a general rule, the mild to moderate cases of C. diff, in other words, those with a white blood cell count of below 15, should be treated with Flagyl. And I see another mistake that's being made a lot. Some docs are using IV Flagyl as their first-line treatment, especially in patients that have a functioning gut. But if the gut is functioning, the first-line treatment for C. diff is oral Flagyl. And then if the white blood count's above 15, you'd use oral vancomycin. And in treating any kind of bacterial infection, we always want a concentration in the infected tissue of the antibiotic that exceeds the MIC, or the minimum inhibitory concentration of the organism, by 4 to 8-fold. So Flagyl exceeds the MIC of C. diff by 10-fold. So in other words, it's killing the organism pretty well. 125 milligrams of vancomycin exceeds the MIC of C. diff by 1,000-fold because it is highly concentrated in the colon. You do not kill C. diff any better by giving 250 milligrams of C. diff and getting an MIC that's 2,000-fold greater than the MIC, or 500 milligrams to give a much, much greater than the MIC. The only time that I use a higher dose of the vancomycin in treating C. diff is if there's some question of the gut function. If the patient has some ileus and there's some question as to transition of the vancomycin from the stomach down to the colon, as there would be a concentration gradient going down the gut. To make sure we get enough of the drug to the colon, then I might give 250 milligrams. Otherwise, 125 milligrams should be sufficient. But let's talk about prevention. Preventing C. diff from happening, the best ways of doing that are reduction of antibiotic misuse and overuse, hand hygiene, and washing, because remember, the hand sanitizers do not kill the C. diff spores. Personal infection control, in other words, wearing your gloves and your gowns. Reduced use of proton pump inhibitors, because stomach acid is actually a great barrier against C. diff. Of note, probiotics are really not effective, and I see probiotics used almost universally. If you look at the published guidelines on C. diff, probiotics are not recommended for use in prevention of C. diff, at least the probiotics that are available right now on the market. And then stressing really meticulous hygiene to the patient at home, because C. diff has about a 20% relapse rate, and the reason for that is reinfection. And it's very easy for the patient to reinfect themselves at home if they don't know about wiping down all the surfaces with bleach-containing material and laundering their sheets and towels and stuff like that. So let's address this issue of I use antibiotics to avoid getting sued. Several studies have been done that show that many doctors prescribe antibiotics out of fear that they will be sued. And this is one reason why antibiotics are overused. However, there are no studies that have been done that show that antibiotics protect doctors from litigation or bolster a physician's defense if they are sued. Now, all I can provide for you here is my own personal experience as an expert witness in many malpractice cases. I've seen cases where negligence was alleged when antibiotics are not started in a timely manner in cases of true infection. Negligence was alleged when the incorrect antibiotics were employed and clinical guidelines were not followed. Negligence was alleged in cases when side effects or allergies to antibiotics were not recognized in a timely manner, such as renal failure, etc. And negligence alleged in cases when harm is done by unnecessary antibiotics or administration thereof, such as Lyme, sepsis, etc. And all these patients were receiving antibiotics. So in these cases, the antibiotics did not protect them in any way. So the use of antibiotics did not protect these doctors. However, in my experience, and this has also been shown out to be true, the absolute best defense in court cases and in litigation is to follow published clinical guidelines. And we'll get into clinical guidelines a little later. So let's cover the outpatient antibiotic stewardship issues. Pharyngitis. Probably one of the most common reasons why patients go to see their primary care doctor in the office is they have a sore throat. Only 10% of pharyngitis in adults is bacterial, 90% is viral. Yet, 70% of patients, when they go to see their doctor, will walk out of there with a prescription for an antibiotic. Just a little hint, bacterial pharyngitis does not cause stuffy nose, runny nose, does not cause catarrh, causes no nasal symptoms. That is a big clue as to viral syndrome. Also, oral examination is only 50% sensitive in diagnosing bacterial pharyngitis. In other words, it's a flip of the coin to make a diagnosis of strep throat by looking in the throat. Here's an example. The picture on the left is strep throat. And this is kind of the strep throat you'd expect to see. Big tonsils, purulent. The picture in the upper right is also strep throat. Big, inflamed tonsils, but they're not purulent. The picture on the lower right is a viral infection. This is Epstein-Barr. Also enlarged tonsils and also purulent. So you really can't tell by looking in the throat that one of these is strep throat, but I can guarantee that the left one and the right lower one will be given an antibiotic. And probably all three of those would be. Another outpatient overuse of antibiotic is something called asymptomatic bacteriuria. And asymptomatic bacteriuria is actually has a published published guideline in Infectious Disease Society website. Asymptomatic bacteriuria, by definition, is presence of bacteria in the urine of a patient without symptoms of a urinary tract infection. And usually the colony count of organisms in the urine is greater than 10,000, and most of the time is 100,000 colony-forming units. There may even be some white cells in the urine. The incidence of asymptomatic bacteriuria starts at about 1% in teenage girls and continues to increase as women get older. And in women over the age of 80, it's greater than 20%. Asymptomatic bacteriuria does not progress to urinary tract infection and therefore should not be treated. And yet, there are many people, many primary docs, that as a course of routine will obtain a routine urinalysis and urine culture on their patients. And when they find a positive urine culture, they will give that patient an antibiotic. And I've had patients referred to me because of recurrent urinary tract infections. And the patient will come to me and say, "Doc, my doctor tells me I've got recurrent urinary tract infections. He checks my urine and finds a UTI, gives me an antibiotic, and then rechecks my urine. It's still positive, gives me another antibiotic. And then I ask the patient, well, what are the symptoms that you have? How do you know you've got a UTI? Well, I don't have any symptoms. It's just my doctor tells me I've got one. Well, then you don't have a urinary tract infection. You've got asymptomatic bacteriuria. Stop getting urine tests. That's the cure. In fact, the Infectious Disease Society of America, in their clinical guideline, advises against routine urinalysis and urine cultures, except in the case of prenatal care and preoperative workup for urological procedures. Another place where you've got outpatient antibiotic misuse is gastroenteritis. Gastroenteritis is by far and away a viral infection. Bacterial gastroenteritis is a self-limited disease. E. coli, Salmonella, Shigella, Yersinia, Campylobacter, self-limited. You don't need to treat them. It goes away on its own. The only time you really need to treat bacterial gastroenteritis is in cases of dysentery where you have fever and bloody stools. And yet, 9 times out of 10, when someone has gastroenteritis, and we see this all the time in the ERs, they're given Cipro and Flagyl. Even that combination doesn't really make a lot of sense. The Flagyl especially, because E. coli, Salmonella, Shigella, Yersinia are not sensitive to Flagyl. And of course, the Cipro is not necessary because the bacteria are going to resolve on their own anyway. Cipro and Flagyl are great drugs if it's diverticulitis, but hopefully an emergency room doctor should be able to make a diagnosis of diverticulitis and distinguish that from gastroenteritis. And C. diff, you ought to be able to distinguish that also from gastroenteritis, and Flagyl would be effective there. The Cipro would not. Bronchitis is also predominantly a viral syndrome, and yet patients are constantly given antibiotics for bronchitis. Really, the only treatable causes for bronchitis are mycoplasma and chlamydia, and are only less than 5% items. So these are some of the problems that we have with antibiotic overuse. So what if the patient insists on an antibiotic? I came to see you because I'm sick, and I'm not walking out of here until you give me something to help me feel better, and I want an antibiotic. Education does help. Now, yeah, it may not always help, but I think that the perception of most doctors is that they're real busy. They don't have the time to sit and talk to a patient and explain things. It's easier for me to just give them an antibiotic and get them out of my hair. I don't think that it really takes that much time to explain to a patient that what you have is a virus. Antibiotics have no efficacy against viruses. This antibiotic has a greater chance of causing problems in you than of actually resolving the problem. And it probably only take you a couple of minutes to explain to the patient. And I would be willing to bet that the majority of patients would understand. Just to round things off here, some other issues. Underdosing antibiotics encourages development of resistance in bacteria. Inadequate serum and tissue levels selects out the intermediately sensitive or more resistant subpopulations of organisms, which then become the dominant subspecies or the dominant organism of the population. So it's always better to overdose an antibiotic. I know the pharmacists don't necessarily like to hear that, but antibiotic doses can safely be pushed higher than usual, so little harm is done. But bacterial inhibition and killing is then maximized. And if you have any question about a dose of an antibiotic, look it up. This is just kind of I made this graph up. This is the best I could do to try to illustrate the point. Each of these bars represents a subpopulation. Let's say that this is a pneumococcus in a pneumonia, okay? And a pneumonia in a lung. And these are all subpopulations of a pneumococcus. Now, the vast majority of the pneumococcus are subpopulation 1 and 2. And we're giving this patient Rocephin. And the concentration in the lung of the Rocephin is 8 micrograms per deciliter. Well, so we're killing with the 8 micrograms per deciliter all the different subpopulations, even these really small subpopulations, subpopulation 3 and subpopulation 4. Well, let's say we underdose a little bit and we don't quite give as much of the Rocephin. And the concentration of the Rocephin in the lung tissue is actually 6 micrograms per deciliter. Now we're killing subpopulation 1 and 2 and 3, but you see subpopulation 4 can survive. And so eventually subpopulation 4 may be able to become the dominant organism eventually. Or let's drop that concentration even lower. And if we give even less Rocephin, okay, sure, we're still killing the majority of the organisms, subpopulation 1 and 2, but let's say we're giving only enough to have a concentration in the tissues of 4 milligrams per deciliter in the lung. Now we're letting both subpopulation 3 and 4 survive. We're not killing completely all the bugs that are there. And now that organism is allowed to survive, and the more resistant subpopulations become the predominant population. Antibiotic de-escalation. The recommendation when you have a septic patient is to treat broad and then narrow. So when the patient first comes in the hospital, we don't know what organism is causing the infection. So we want to make sure that we're covering our bases. And so we'll have gram-positive coverage, gram-negative coverage, and anaerobic coverage. And then as the cultures come back, which generally takes about 48 hours, and as more data comes back in x-rays, histories, other studies, then we realize that, well, we don't need certain coverage. Maybe we don't need the gram-positive coverage. Maybe it's evident that this is a pyelonephritis, therefore we don't need vancomycin. Then we can start stopping antibiotics. That's called de-escalation. We can narrow down the coverage. De-escalation, generally, we want to do that by about 48 hours. And the reason why is that should have blood culture results back at the 48-hour point. Urine culture should be back, and we should have a lot of the x-rays back. So we'll change antibiotics based on sensitivities. So we may start with Zosyn and vancomycin, and then when we have a urine culture that grows an E. coli that is sensitive to Rocephin, we'll de-escalate down to Rocephin, a much narrower range of sensitivities, very narrower range of spectrum of activity. If after 48 hours cultures are negative, then we need to kind of reassess things and rethink things. Just because cultures are negative doesn't necessarily mean there's no infection. Cultures are not always 100% sensitive, but we need to rethink things and reassess the situation. Some organisms are very hardy, and as a general rule, if they don't show up in culture, they're probably not there. Organisms like this would be Pseudomonas or Staph aureus. So if MRSA doesn't show up in culture, you're probably pretty certain that it's not there, so you can drop the vancomycin. Or Pseudomonas, if it's not there, you're probably pretty certain you're not going to need that cefepime or the meropenem, so you can get that off. Other organisms are a little harder to grow, so someone that comes in with a severe community-acquired pneumonia, for example, Streptococcus pneumoniae is a little more fastidious, harder to grow, so you're going to want to keep some pneumococcal coverage on there. But reassessing might involve repeating cultures, repeating x-rays, but still, you probably don't need that broad coverage. You can still de-escalate a bit. Also, de-escalation involves stopping antibiotics when you don't need them anymore. There's only a handful of infections that have well-described recommended durations of therapy. Osteomyelitis, endocarditis, bacteremia, meningitis, they all have these, okay, this is how long you treat. But other infections, such as pneumonia, skin infections, wound infections, you basically continue antibiotics until the infection is improving, and then you can de-escalate. You don't even necessarily need to continue the initial antibiotics until the infection's completely gone. You can de-escalate. I've seen studies that show that all you need for pneumonia is 5 days of antibiotics total. And when the chest x-ray is improving, white blood count's improving, doesn't even have to be completely normal. You can switch them over to an oral antibiotic. A really important point as far as antibiotic stewardship is antibiotic allergies, because this cuts into the best use of the best kinds of antibiotics. And the problem comes with a misunderstanding of allergies. And a lot of docs just pass off allergies because I guess they're in a rush, and the patient says, I'm allergic to penicillin, and they just put that down and they don't explore it any further. A lot of patients just assume that any sort of adverse reaction to any sort of drug, antibiotic, whatever, is an allergy, but that may not necessarily be true. It's really crucial to get a specific allergy history. Otherwise, the patient may end up being treated for an infection with a less effective second or third line antibiotic. As you know, there's two general types of drug reactions. There's delayed or cell-mediated allergies. These are typically milder and cause macular papular rashes, but can be severe, like Stevens-Johnson syndrome. And then there's immediate, which are usually IgE-mediated, which are usually more severe, like tracheal angioedema or anaphylactic shock. These are not on the same. They're not on the same. One does not run into the other. So someone that has a rash, if you keep giving them the drug, they won't have an anaphylactic reaction eventually. So if there's a mild allergy to penicillin, it's fairly safe to give them a cephalosporin. But you have to know what the allergic reaction is. These are not true allergies. GI symptoms, thrush, a family member was allergic, local injection reactions. I've had some patients tell me, I'm allergic to penicillin. Well, what happened? Well, I was given penicillin and it didn't work, so I must be allergic. You've got to really get into asking them the detail. There's also a myth that 10% of cephalosporins will be cross-allergic with penicillin. In other words, 10% cross-allergenicity of cephalosporins with penicillins. This results in, the big red flag from the pharmacy. Uh-oh, you started a cephalosporin. Patient is allergic to penicillin. And actually, studies have been done that show that there's only a 1% cross-allergenicity between penicillins and cephalosporins. So we need to be a little less anal about that. I'm not going to get too much into surgical prophylaxis. There is a clinical guideline on that, and here's the reference. As a general rule, the duration should not be more than 24 hours from the start of surgery. And I'm not going to get into a whole lot of clinical guidelines because they're all available to you. This is idsociety.org. This is the Infectious Disease Society website. This has a slew of infectious disease guidelines. They're categorized under antibiotic agent use, infections by organ system, infections by organism, and a variety of guidelines. These are all readily available. You don't have to be a member of ID Society. All these things are available, and the guidelines will help you in optimizing your care of patients, improving quality of care, and protecting you legally. And I strongly recommend downloading them. They actually have these little mobile cards, they call them. You can buy them for like $7, and they're little summary cards that you can put on your mobile device that summarize these guidelines, and you can kind of flip through them and see them. So in conclusion, misuse and overuse of antibiotics is a major problem and harms quality of care. Antibiotic stewardships aim to encourage proper use of antibiotics. Indiscriminate use of antibiotics can be prevented by education. It doesn't take an infectious disease specialist to understand and apply the basic concepts. And I guess this may be a little strong of a statement, but perhaps based on the knowledge and resources that are available, I suppose it can be said it is unethical to give antibiotics when there really is not an infection. Thank you very much.